Good morning, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we have the pleasure to have Dr. Toni Choueiri, who's a world renowned medical oncologist at the Dana-Farber Cancer Institute, where he's also the director for their Genitourinary Oncology program and professor of medicine at the Harvard Medicine School. In our discussion with Dr. Choueiri, we're hoping to focus on clinically relevant GU studies that were presented at ESMO 2022. Without further ado, let us welcome Dr. Toni Choueiri.
Oh, thank you. Thank you, Rahul. Thank you, Rohit. The OncBrothers. It's a pleasure. This is my first time. Hopefully, it won't be the last time. ESMO 2022 was very, very rich in science, in clinical trials. All of them practice informing, some of them practice changing. And GU was really highlighted very much so. We've seen a lot of new data, a lot of phase 3 trial, and out of 11 presidential presentation, 3 were GU. So it tells you something.
Well, thank you so much, Dr. Choueiri. We're looking for a present meeting and many more in future. So,
Great.
diving into our first study, EV103 cohort K especially, we're looking at this study, particularly cohort K, for cis-ineligible patient population with advanced bladder cancer. Can you please walk us through the study design and its findings?
Yeah, I mean, this study builds on the antibody drug conjugate, EV, enfortumab vedotin, and the combination. And this follows on cohort A, which was a 40-patient study in cisplatin ineligible first line urothelial cancer, where responses were seen, near 70%. So cohort K takes this cohort A to the next level by randomizing patient to pembrolizumab plus enfortumab vedotin, let's call it EV, or enfortumab vedotin first line. So 151 patients that are overall cisplatin ineligible, and shows a response rate of 64.5% in the combination compared to 45% in EV monotherapy, knowing that almost every patient, over 95%, had some sort of tumor shrinkage.
So, Dr. Choueiri, given that this was still a phase 2 study, would you be offering this outside clinical trial?
So, a great question, actually. And I would say, despite this is not approved, we have seen approval of single agent checkpoint inhibitor in cisplatin ineligible patients. Now, this is because these patients didn't have much option with all the fever around checkpoint inhibitor. But this seems to be real. If you look also at the progression-free survival at 1 year, 55 versus 35%. If you look at overall survival at 1 year, which is quite immature, but there's a 10% difference favoring the combination. And furthermore, despite, there are toxicity, no doubt, when you add uh, EV, when you add Pembro to EV, but there is nothing that seems to be a new signal. Peripheral neuropathy is the most common reason for treatment-related discontinuation, and I think the community is getting more and more familiar with EV neuropathy. I think this is very close to prime time. There is a phase 3 study of EV versus chemotherapy frontline that involves cis eligible and cis ineligible. And we could wait for that, but in the interim, I think I wouldn't be surprised if, based on 150 patient study, this regimen, will be approved, very possibly. So, are we ready? I think we are very, very close.
Well, thank you so much for sharing your thoughts on that. Now, let's dive into our second study, Radicals HD. Here, we're looking at the duration of ADT for early prostate cancer patients in adjuvant settings. Dr. Choueiri, can you please walk us through this particular study?
Yeah, I mean, this study was presented in the presidential session by Dr. Chris Parker here. It's an interesting study that asks an important question that been elusive for some time. What's the duration of ADT post-radiation for prostate cancer? Knowing I'm going to start telling you that a lot of folks practice salvage radiation in this day and age. So we'll discuss that in a second. And how this radical study in terms of eligibility, it took patients with post-op, due for post-op radiation after radical prostatectomy, and excluded patients with prior hormonal therapy or metastatic disease or high PSA. The interesting part is the randomization was three-way or two-way randomization, meaning there were around over 1,000 patients that were randomized RT alone or RT plus short hormonal treatment. Another randomization, also over 1,000 patients, short versus long. And there was a three-way randomization where, the three arm. And then the author a bit pulled all these, RT only and RT plus short-term hormonal therapy together to increase the power, as well as did the same for short-term versus long-term. The bottom line is when you look at the short-term 6 months of hormonal therapy, and when you look at the primary endpoint, non versus short of metastasis-free survival, there was no difference. The hazard ratio was 0.89. There was no difference in metastasis-free survival and freedom from distant metastasis. The difference was obviously time to salvage hormonal therapy. And you ask yourself, even after many, many years of follow-up, if they are powered enough. And then you ask yourself, are these patients that were randomized, patients with very low risk disease that radiation alone, may have been enough? But I think the big news here is the short versus long. And if you look at the patient characteristic there, the patient had a higher baseline, adverse prognostic feature. For example, in the short versus none, 12% of patients had the Gleason 8 to 10. That's the highest risk, 12%. When you look at short versus long, around 30%. So, there is some selection. But here, metastasis-free survival benefit was achieved, and there was 10-year, 6% difference, statistically significance, favoring long-term, 2 years hormone therapy. Overall survival, no matter what, is negative. This is, very few events. So over, where are we here? Because this is a bit, I'm not sure I can say that this is not confusing, but this is a large randomized controlled trial with follow-up 10 years and pre-planned meta-analysis. The limitation is that in good prognosis patients, the survival data is immature. And now we do a lot of, at least in my clinic, early salvage RT over adjuvant RT. And, pelvic node radiation is increasingly used. But I think what I take from it is that when added to post-op radiation, long course ADT compared to short course ADT, improve metastasis-free survival. So if you want to do something, it's long course ADT, and partly because the patient characteristic and there is more adverse, baseline characteristic.
Certainly, there is quite a bit of advantage seen with the long term, but again, it is important to reiterate to individualize treatment for the right patient population. So thank you so much for going over that, Dr. Choueiri.
Absolutely, yeah.
So diving into our next study, adjuvant study for atezolizumab in RCC patient population, IMMotion 010. We have pembrolizumab approved in the setting from your landmark Keynote 564 study. Can you walk us through the study? And in your opinion, are all PD-L1 or PD-1 inhibitors the same?
Yeah, no, that's good. I don't think all PD-1 and PD-L1 are created equally. And I think also the trials are a bit different here. IMvigor010 is a study we were waiting for a long time. This is a study of adjuvant atezolizumab, the PD-L1 inhibitor, in high-risk renal cell cancer. Atezolizumab has activity in renal cell cancer, but the front line in a study with bevacizumab, despite the PFS advantage, really did not pan out. And this combination, atezo-bev, despite its tolerability, is really not approved. The field is driven by PD-1 based TKI. So this study randomized patient to a year of atezolizumab or a year of placebo, and including high risk populations, so T3, T2 high grade, T3 intermediate and high grade, N plus, M positive. There was no difference in investigator assessed disease-free survival at all. The hazard ratio was 0.93, neither in overall survival. There was some signal that potentially PD-L1 positive patient more than 50% may have something, but this was not, this is a small subgroup analysis. The drug also was tolerated, and I think the authors are going to have a work on biomarker. I cannot say for sure at this time really what happened, except the drugs are really different. Pembro is not atezo. There are differences also in eligibility and difference in the baseline characteristic. We used a different model here with intermediate, high, and M1 NED. And also, the Pembro study is larger by 200 patients. So need to be seen, but the data is actually the data. And it's not surprising that the PD-L1 inhibitor has failed, because if you look at the frontline RCC, same story repeated. If you look at something very similar, which is, I would say, second line bladder cancer, different diseases, Keynote 045 versus post chemo versus the adjuvant study, the metastatic study with atezo, both against chemo, also didn't pan out. We have to see. I think Pembro is alone here in this space, and Pembro does have I would say, a trend toward overall survival. Still very few events. If overall survival is going to be reached, I think, can't anymore argue with this.
Perfect. As we wait on the overall survival data in that settings, we can now move on to our last study presented by you and discussed by Dr. Powell from City of Hope, Cosmic 313. Dr. Choueiri, stage is all yours.
So this was a great experience, to present in the presidential session, the third day, Cosmic 313. This is the first study that is in metastatic RC frontline that uses a modern control. It uses nivo-ipi, so it uses a doublet. This is not sunitinib. So building on nivo-ipi, in intermediate and poor risk, where nivo-ipi was approved, we asked the question whether adding 40 milligram of cabozantinib will improve outcomes. The primary endpoint was PFS and was met. There was a 27% decrease in the risk of progression or death in the triplet arm. So overall survival, we did a press release. It's too early, too immature. Response rate were numerically higher, but the CR, complete responses in both arms, were very low. We're trying to see why. One of the reasons is 1 out of 3 patients had their kidney in. This is the study, the frontline study, that has the least nephrectomy. And, if you consider nephrectomy as a target lesion here, then, it's near impossible to have a response there. Toxicities were higher, especially LFTs elevation and diarrhea and hand-foot skin reaction. So luckily, this has not led to an excess death on study from treatment, and the treatment discontinuation of all the drug used in the study was 12% versus 5%. Interesting enough, we did a subgroup analysis that showed most of the benefit happened in intermediate risk patient, which is a large subset. It's 75% of all patients. And this is a bit counterintuitive because you would think the triplet will work in poor risk more. But also I would say that perhaps the poor risk are, very poor risk that, TKIs don't work, or even you barely can give any drug. So you need the patient at least in relatively okay shape to be able to give 3 drugs. We're digging into this as we speak. But it was a great, study to have and to try to push the field forward that, we may be now trying 3 drugs instead of 2.
Absolutely. As you've mentioned, we have PFS right here. We'll be eagerly waiting on OS data to see how we incorporate this in our day-to-day practice.
Dr. Choueiri, thank you so much for taking the time to discuss this practice-changing studies with us today. We hope that our community medical oncologists will get a chance to incorporate this new data into their daily practices. Thank you so much again for your time.
No, thank you, and please have a great day.